Focusing on how best can we work in a system that allows patients to get the care they need, while also focusing on how do we ensure our family physicians have the right support.
Getting rid of negation, I got to make sure I get all my terms right. This was a source of stress, right?
Yes.
For family physicians. Could you talk a little bit about that? Outside use, when a patient who belongs to a clinic goes and uses a walk-in, in the previous model, the family doctor of the clinic would be negated, which means they would lose the value of the service that the patient obtained at the other clinic.
Sure. Yeah, on a one-to-one basis. And so I think, and David speaks more eloquently to it than I do, but I think that the concept is around some accountability. Like that I think was the genesis of this, that, we are being paid for longitudinal care for a panel of patients or a roster of patients. And so the idea that if they ever didn't see us for something that was included in that sort of capitation model, that somehow we had failed them in a very simplistic way, that we had somehow failed them by not being accessible. And what it doesn't do, obviously, is take into the consideration the complexity of factors that drive patient choice. This is not just a doctor issue, as Jobin said, it's a patient issue. When my patients up north, I mean, I don't know what you think of this, Anthony, but the patients up north at the cottage and they get hurt, is the right thing for them to do to worry about their doctor and say, oh, I have to go to the emergency department because God forbid I go to a walk-in, or to take their child to a walk-in appropriately? And is that a failure for myself that I wasn't able to drive with a portable x-ray machine 5 hours up north? I don't think so. So the point is that there are some unintended consequences to, and I mean, I give a sort of facetious example, but it's true for so many people. Like, let's think about from an equity point of view. Some people can't take time off work. They don't have the agency to do that. They have to work. And so we can offer them, of course, we do offer them evening hours. All of us are obligated to give evening hours and weekend hours. But at the end of the day, we can't assume that in every situation a patient gets sick quite at the time that they need to. And so they have to have the ability to seek care other places. And so what was happening is that these patients then would essentially get called by their family physician's office to say, it doesn't look like you're following up with us and with our after-hour service and our access, and then that just creates a feeling of guilt from the physician whose office is already overburdened and frankly doesn't want to make that call. Right. And for the patient who, like Jobin says, almost feels like they did something wrong, and as David said, like it can create some tension. And so it's just a lot of unintended consequences. That's a very simplistic way of thinking about negation. We get negated for hospital code. I mean, there's a lot of strange things that we get negated for. But the idea is, how do we actually build a system that's connected, that understands that our fee-for-service physicians or focused practice physicians who are not designated as such, they're part of a system, and the only way you can be part of a system is to think about things a little differently. And so while I can sort of understand perhaps where it may have come from, it certainly has been not successful and created a great deal of tension. So this is something for sure. I think, David, you would probably say we don't get a lot of unanimity in what people don't like, or on agreement about one thing, but family doctors were very, very lockstep about getting rid of negation. So that is a really big achievement, I think, of this full plus model.
Well, I mean, Sharon's exactly right. I mean, it's that tension that it creates, between the patient and the doctor, that's the last thing we need in our day-to-day practices, really. And then, then you get into sort of gaming of the system. And, if a patient is going, if they're going too much out of, we're going to see other practice or the physicians, and, are getting negated, then, if it reaches a certain threshold, then we de-roster that patient, right? And so it's just a gaming thing. It just doesn't help anybody, honestly. And Sharon's right. It's a government's way of trying to make sure there's some accountability. But I personally. We're professionals, and I don't really. It's like lawyers don't have accountability; they bill, and they're professionals, and so I would say the same thing for family doctors. Like, why do we have to have this, accountability pieces? And with Full Plus, it's going to look, much different. Bill Kaplan, the arbitrator, and he thought we asked for no accountability. I mean, we're accountability, we're accountable on our own. But the arbitrator thought that there had to be some measure, and even the new measure, they're like really stressing people out. I mean, they're really freaking out about the new accountability measures because nobody really knows what it's going to look like and how much impact is going to happen. Is it a dragnet that's going to catch a lot of, really innocent county doctors, when it shouldn't be. So we have to work at that piece for sure.
Yeah, and I think one thing I would really focus on is the idea that what we want to get to, where the end goal in all this is, we get to the point where every Ontarian has access to a family physician that they can get to easily. What we don't want is a system that then penalizes them from actively receiving services from people that are actively trying to help them. And nobody wants to be in a system where they're constantly having to juggle, should I go X to get my care, or should I wait a certain amount of time only to get worse and then go to my doctor and then they say, well, why'd you wait so long, right? So, I mean, I think the system needs to follow care. And that's one of the biggest things is patients benefit when it's a system that can work together. But that also comes to that interoperability that needs to be present too, in order to make sure that the care can actually work in a way that, as a family physician, I receive the information about the need that this person had to go seek care elsewhere. That doesn't exist. And that's what needs to kind of get worked on instead of these accountability measures that was mentioned. Instead of getting to a point of, well, we're going to work on regulating because, the self-regulation is not something we're okay with. That's a mistake. In my mind, self-regulation allows us to really innovate and be as strong as we can, working within the systems we have locally, and then working to build solutions provincially.
If you like this clip, you want to see another one, click here. If you want to watch the full roundtable, click here.